healthcare reform. We're pleased to be joined today by our presentation today will be by Barbara DiPietro, who is the Senior Director of Policy for the National Healthcare for the Homeless Council. Of course, been tracking really closely all of the proposed changes in the bill that passed the House. And we'll be talking today about proposed changes impacting Medicaid enrollment and continuity of benefits. This is Marcella McGuire from CSH, and Barbara, I'm going to hand it over to you. Thanks so much.
Thanks, Marcella, and appreciate being here. Thanks, everybody, for coming just for a quick half hour on this particular topic, a segment of the health reform bill that's going through Congress. As we know, passed out of the House, the American Health Care Act on last week, and is now headed to the Senate. So we don't know what's going to happen in the Senate at this point, but we do want to be looking really carefully both at what the federal level is doing with the American Health Care Act, but also asking folks to look at what their states are doing and what can happen both at the state level and from an administrative perspective. So with that in mind, kind of looking at a two-track monitoring, let's just plunge in and take a look at what are the things that specifically are going to relate to the enrollment piece and the continuity of those benefits. I think it helps to just get a sense of where we were in the fall, where it was all steam, full steam ahead. We were looking at improving coverage, access to care, a lot of attention toward how can we be getting people who were not yet enrolled into the insurance pool. You had a lot of work happening at pretty much every state level, looking at how to establish value, moving to a payment reform system that looked at quality and outcomes rather than a fee-for-service kind of quantity over quality kind of piece. And so looking at how do you retool a whole delivery system. You saw that Medicaid in particular was really front and center, particularly obviously in Medicaid expansion states, where we were strengthening those partnerships with managed care, figuring out what were innovative principles that states could do at the state level, or we were doing innovations or demonstrations at the individual plan level to figure out how could we be turning the curve on quality and cost and all of that, and of course more fully integrating care so we could be delivering really high quality, comprehensive, integrative care to vulnerable populations. What we saw coming through quite unexpectedly, a lot of this has been unexpected and a lot of it is happening very quickly, and so if you're feeling like you don't know what's happening in the nation, it is fine. Absolutely, a lot is happening and it can be pretty confusing and overwhelming. So let's just kind of break it down little by little. With regard to some of the big pieces in the American Health Care Act specific to Medicaid, we know that the bill repeals the Medicaid expansion come 2020. And at that point, it moves to per capita caps, where they'll put people in different population groups and then have a different per capita cap per population. There's also an option for states to choose a block grant if they wish. Now, what you may have heard is that there's a state option to do an essential health benefit, a waiver on essential health benefits. That's at the state for private plans. What is not being talked about is that the American Health Care Act repeals essential health benefit requirements for Medicaid plans on states that have done an alternative health benefit package. And so, again, thinking about what are the different rules for Medicaid versus private plans. This does repeal that essential health benefits piece for Medicaid. It ends retroactive coverage and presumptive eligibility. And from a provider perspective, in the healthcare for the homeless world, these have been really important keys into ensuring some continuity of care, but also good tools for keeping people and getting people enrolled and keeping people enrolled. It sets up a state option for work requirements. And then it does require stronger documentation prior to enrollment, so it really moves away from self-attestation and moves into you have to have all your paperwork up front, and it moves to a redetermination in Medicaid every 6 months. And we know that this is a big change. All of these are really big changes. Overall, when we looked at the Congressional Budget Office score that had come out in March, this is what everybody was talking about, is that this is a really substantive change that's going to risk coverage for a lot of folks. So over the next 10 years, they had anticipated that 24 million people broadly would lose coverage, and 14 million of that would be from Medicaid. And you can see the substantive loss of investment in Medicaid, specifically because you're moving away from the expansion and you're going to a block grant or a per capita cap. And the reason why, really the only reason why you would go to a cap or a block grant is to control cost. It doesn't really have anything to do with the types of services or anything that people get. It's simply you're going to limit the amount of money you put into it. So this sets up then a chain of reaction on what happens at the state level, and I think that's something that we want to talk about today as well. So 4 things. One, for today, let's take a look at what a baseline is in terms of where is insurance coverage for people experiencing homelessness currently. What are the provisions in the law that impact enrollment and continuity of benefits? Where is that going to go at a state level? So again, individual states have got a lot of flexibility to do some of these same things. And then particularly, what can you be looking for and where can you be active and being able to direct a lot of your energy and focus in making sure that we've got a system that can accommodate people experiencing homelessness. So with those 4 pieces in mind, and for the next 20 minutes or so, let's just get kind of a broad brush. So Healthcare for the Homeless projects, as you may know, were federally qualified health centers that serve people who are experiencing homelessness, comprehensive outpatient primary care and behavioral health, along with a lot of case management, care coordination, and a lot of those supports that make the medical care work. By no means do we see everyone experiencing homelessness in the United States, but across 300 projects last year, we served nearly 1 million patients. And so this is kind of just a broad brush strokes in terms of the data that we have on the insurance coverage for our patients. So again, it's a litmus test for kind of where we might be, and then we divide that out by states. And one of the things that I think is important to remember as a baseline, even going into some of these changes, that eligibility does not equal enrollment, and enrollment doesn't always translate into access to care. So there's 3 pieces that we really need to focus on. Obviously, the eligibility piece. So in states that expanded Medicaid in 2015, you can see that this is a percentage chart by state on the percentage of uninsured patients at Healthcare for the Homeless projects in those states. And you can see a really wide variation here. And we know that there's a lot of reasons why someone may remain uninsured. They may not be eligible for coverage. They may not have paperwork. They may be so unstable that they're not able to complete an application. It may be that they're in and out of justice systems where their eligibility gets terminated a lot, and that can happen, as we know, many times within a year. So there's a lot of different variation here. But you can see even in states that have really put their all into enrollment and connecting people to benefits, you still are seeing some pretty high rates of ongoing uninsured. Then, but part of this is when we take a look at it, we've got a lot of folks that have decreased. These rates are significantly decreased from where they were in 2013 prior to where the Affordable Care Act's expansion went into place. So let's not overlook the progress that's been made, but let's also not presume that, again, because people are eligible that they are enrolled. So that's the takeaway there. When we look at states that have not expanded Medicaid, it's probably not a big surprise that they are remaining at really high rates of uninsured because the single non-disabled population is primarily what Healthcare for the Homeless projects serve. You see ongoing a lot of uninsured folks because they're below poverty in a state that didn't expand Medicaid. It means they don't have any option. So for those who may have income and earn over 100%, they may be able to get a subsidized plan on the exchange. As we know, however, many of those plans come with, even though very, very low premiums, they may come with high out-of-pocket costs like deductibles or copays that are going to be barriers to care for our population and may lead people to forego insurance altogether rather than be able to pay that. So I think it's important to take away from these 2 slides is that there's still a lot of work to be done And that's before we even talk about some of the barriers that we're seeing be proposed. So with that in mind, just kind of coming back to the American Health Care Act, these are the pieces that are going to impact enrollment. So obviously block grants and blocking an option to expand. So just cutting off the eligibility for expansion to begin with obviously is going to be a barrier. They anticipate gradual disenrollment. So one of the things is there's a provision there that says for people who've managed to maintain continuity of Medicaid benefits without any break in coverage more than a month, that they'll be able to stay on Medicaid. But what that belies is that any break in coverage is going to be more than a month, because typically what happens is that your benefits don't kick in until the beginning of the following month. So any break is really going to be for more than a month. And when we look at the kind of attrition that we see currently, Health Affairs has done some really interesting work on churning. So that term meaning either churning off of benefits, meaning from Medicaid into being uninsured, or churning between Medicaid coverage and perhaps a plan on the exchange, and churning back and forth between Medicaid and private coverage. So that kind of shifting over between either insurance status or insurance plans can create a lot of noise and a lot of havoc in what benefits you're eligible for, what doctors you can see, how you are able to use your health insurance. And sometimes, and what Health Affairs has found is that within a 12-month period, 40% of Medicaid beneficiaries will lose coverage for some reason during that year. And so when we talk about, or when the American Health Care Act talks about, oh, well, you can maintain your benefits. If you maintain your benefits, you maintain your eligibility for Medicaid. It belies the significant amount of churning that's already happening. And so what they're counting on is they're counting on that kind of churn, which is why they put a redetermination every 6 months. And as we know, every 6 months, particularly for people experiencing homelessness, is going to be a really high bar to meet. Because right now we're having a hard time doing a redetermination every 12 months. So with twice as much redetermination, you'll probably see twice as much churn. And so we'll see people cycling off of benefits. And then that cuts that piece where they then can't get back into the Medicaid program. They fall under the capped or the block granted program. So that's kind of what is envisioned there. The law does limit retroactive coverage, so we're not able to do a look back and be able to get someone's services that they may have had in the last couple of weeks or months paid for through Medicaid. It does require stronger documentation, and anyone working with this population knows it's very hard to verify identity or get ID cards. Those are the kind of things that really get taken or lost or stolen a lot. Presumptive eligibility is something that we've relied heavily on because of there's no reason to doubt someone's citizenship or income, particularly when you've been working with them for a while. And sometimes you just have to wait for the paperwork to come through. The new provisions would not allow for that. You have to have all your ducks in a row at the moment at which you would get enrolled. And so that is also what we would imagine would be a greater barrier to getting people into benefits. Now, there is a hardship exemption built into the language, but it's unclear how that would be crafted or who that would apply to. But it is worth having here because, again, what is this hardship exemption and how might it be used and under what circumstances? Again, we just can't know that. So that's the legislative piece. Now, when we look at the leadership at HHS that's in charge of Medicaid, these two folks here, Secretary Tom Price, and CMS Administrator Seema Verma. This quote here was taken from a letter that the PDF is in the bottom there. If you get a chance, this is a 3-page letter. Highly recommend that you download it and share it with your networks. This is a letter that invites states to submit waivers to the current Medicaid program. So again, when I started talking about where you need to be looking at the state level, this is where states have a tremendous amount of flexibility on the administrative side and where HHS can grant that flexibility by approving those waivers. And this quote really kind of gives a sense of the philosophy that the administration holds in that The expansion of Medicaid to non-disabled working-age adults without dependent children is a clear departure from the core historical mission of the program. So one of the thing to take away from this is Medicaid expansion is a new population in Medicaid, and many of the people that we are serving are newly eligible for Medicaid, many for the first time. And so this is kind of a hallmark to say, you know, we may not support this population. We may not be really looking to engage this population in Medicaid, or if we do, it's not going to be for very long. And so one of the things that we want to look at here is how will the Trump administration interact with the states around how the expansion population is supported or may not be supported. So in that letter here, it invited states to implement work requirements for Medicaid, introduce health savings accounts, introduce premiums at all poverty levels. So even someone who may have a zero income and be living at 0% of poverty may be required to have an out-of-pocket cost. So that's something that we really want to look at. Indiana has already implemented something like this, and as you might imagine, even though the premiums are only about $12 a month for people living at below poverty, it still is a barrier to care for people who have nothing. Taking a look at waiving presumptive eligibility, retroactive coverage, some of the things that I just talked about that are present in the American Health Care Act are also possible to submit a state-level waiver to HHS and get approval to do. They've also said waiving non-emergency transportation, which we know can really make the difference between someone making it to a medical appointment and someone not being able to navigate 6 buses or a complicated transportation line, even if there is transportation in their community. That can make a big difference, and currently Medicaid pays for non-emergency transportation. If you take that away, it might mean that you take away literally someone's ability to access care. And then what we see, too, are some executive orders that were signed, a little unclear on what the meaning of some, particularly that first executive order meant, but it clearly indicated a lack of support, particularly for the regulations that support the Affordable Care Act. So things that should be looking for, these vehicles for change, the HHS regulations coming out of the federal level, your state submitting a waiver for some of those rules, and then just generally, how are they not enforcing the current laws or regulations that support the Medicaid program? So these are all things that we think are vulnerable. A cartoon here that just really illustrates that a lot of these decisions then push the subsequent decision to the state level. And so what that means for states, when you cut Medicaid and you make it into a per capita cap or a block grant in particular, yes, you're doing this under the guise of state flexibility, but Medicaid is already a pretty flexible state program, and that's why no state's program looks like anyone else's, because everyone is very tailored and individualized to that state's needs. At the same time, when you take money out of it, you essentially are asking states to do what they're doing, only with less money. And usually states have to respond by cutting benefits, cutting populations, cutting provider rates, all the kinds of things that we know will probably yield fewer people getting access to the benefit and fewer people getting access to the care that they need. So this really pushes this down to the state level, and in particular makes things really, really hard on the governor and the Medicaid director. So they have to figure out then what are they going to do, because in order to make up that money by holding everything else equal, it might mean that they have to raise taxes, and nobody wants to be in a position where they're raising taxes. So overall, even though we had all of these really interesting delivery system reforms and innovative partnerships with managed care and people looking to redesign some things, what we're now seeing and we're hearing people say is, whoa, hang on, maybe we should take a step back, maybe we should put our, just put the brakes on a little bit and let's see what's going to happen. And little by little, what I think we'll see is there's going to be a cooling effect on some of these really exciting supportive housing partnerships or medical respite care, things that worked for people experiencing homelessness. All of a sudden, we may not see that same support. And it may be at the federal level, we're getting a very clear direction that that's the case. But at the state level, it may just be that they want to wait and see what happens. So that kind of puts everything on the back burner. So that's something that we're looking at. So I've mentioned a number of these things and just really want to kind of make sure that there's basically a laundry list here of the things that we could see start creeping into plans. And we have started seeing some of these waivers already submitted or being crafted at the state level that contain these pieces. So more frequent redeterminations. So maybe you'll start seeing your state say, oh, maybe we could ask people to redetermine every 6 months. Or maybe we could ask them to have all their paperwork up front and we don't do self-attestation anymore. Maybe we do time limits on benefits. So that means like a lifetime, like what we see under the temporary aid for needy families. 60 months as a lifetime benefit, and then after that you are no longer eligible for Medicaid assistance. Seeing disenrollment for non-payment. So if you have a marginal out-of-pocket cost, if you don't pay that, maybe there's a freeze-out time period where you don't have access to your benefit. Work requirements, we're seeing a lot of states put those in. In fact, just to ring off a few, if this sounds like you out there, Arkansas, Wisconsin, Pennsylvania, Kentucky, Maine, Arizona, all of these are states that are either very strongly considering or have already put in to ask permission to do work requirements. Drug testing for benefits. Again, we're going to start seeing this more and more. Wisconsin has this as part of its waiver. Premiums and copays. We might see reducing eligibility. So as states, again, under the American Health Care Act, if states want to start reducing eligibility, they can do that. Now, again, that's only if the federal law passes. Right now, states do not have the authority to request a waiver to federal law. So that's where kind of states' ability to act and the American Health Care Act as a federal law will be very different. But we do see a risk here of pulling back on. So how will states be less likely to be adding optional benefits if they're going to be getting less money? How will health savings accounts work for people experiencing homelessness? We know from Indiana's experience that they don't work very well. So this is a laundry list. Keep this in your hip pocket because this is what you might see in some combination written in at your state level. Okay, so let's finish just by talking a little bit about action items and so how you can be active here. So one of the things I'm thinking about is how are you active with your Senate? So right now, the American Health Care Act has shifted into the Senate. Are you communicating with your senators? And it may be two things. One, is your senator really awesome and is a supporter of Medicaid and is doing everything they can to protect Medicaid? If so, absolutely make sure you're showing them the love. Make sure that you're calling them, you're meeting with them, you're sending them supportive information. They are going to continue to need fodder to be able to assert why Medicaid is a life-saving program for very vulnerable people. So if you have stories about people who are doing really well on Medicaid, send them to them. If you've got testimony or if you've got data about reduced emergency room visits, or you've got really, people returning to work because of the support they've gotten under Medicaid, reunited with family members, getting better on their health care, able to achieve recovery and sustain recovery. These are the kinds of things that Medicaid we know supports, but let's have those stories be told. So definitely support those that are in line with supporting Medicaid. If you have senators, however, that just you feel like nothing that you say they are going to listen to, that is even more reason for you to say it twice as often and twice as loud. These are stories we know speaking truth to power works. We know that we have to get the story told. And so continuing that drumbeat absolutely is the spirit of what democracy is about, but don't give up and don't feel like your voice is not heard. The House is on recess this week, and so they may be back in your community. If this is an opportunity to meet with your member or call your member's local district office or show up at a town hall, please do. Talk about how important Medicaid is in particular. A lot of the conversation has shifted to the private plans and protecting people who have private plans. And that is absolutely a worthwhile discussion. But when we talk about the health care and the benefits and the continuity of care for people who are homeless, we are largely talking about Medicaid. And if you're in a state that has not expanded Medicaid, it is not too late for your state to expand Medicaid. The Affordable Care Act remains the law of the land, and it's still an option for people to explore. So please push that if you can. Use your local media, write an op-ed, use your Twitter, use your Facebook. These are free and very available platforms to be able to have a voice. We certainly see the voice that the president has on Twitter. This means that everyone has a voice. There's a great equalizing to Twitter. So mobilize and organize and get those stories told. All of these things I talked about here, but being engaged, changing the conversation, speaking up when people talk about the undeserving poor, or buy into a conversation that starts to go down a path where people shouldn't have access to care. Because we would assert that health care is a human right, that people experiencing homelessness do have the right to comprehensive medical coverage that doesn't come from a high-risk pool, and it doesn't come from an incidental fund that's set up to maybe cover some of what they need. They deserve insurance the same as anyone else, and that insurance needs to be accessible to them and comprehensive, and link them to the care that they need. And so I put Congress's number here, the 202 number. If you've got your cell phone out, plug it into your favorites, and then label it Congress. And then as you're driving home or while you're walking down the street, you can say, Siri, call Congress. And that will link you to your member where you can have a conversation and leave a message. Those messages at those offices are being recorded. And every time someone calls in and says, I support Medicaid, that gets recorded on a log, and those Congress members do look at that log. They do keep a running tally of who's calling their office and on what subject. So please continue to be part of that conversation, continue to engage not just with your members, but in your community. Join marches, organize marches, speak out, find places to really engage and continue the Medicaid discussion. Now, every state also has a requirement that there be a Medicaid advisory group. Find out who these people are, get on their email listservs, make sure that you're engaged with the watchdog groups that are already set up to look out for these kinds of things, and make sure that if your state's going to put a waiver in, that there is a requirement for public comment. So you can weigh in and tell them how terrible you think work requirements are, that how unhelpful that you think premiums are going to be for someone living on the street. That's an opportunity. Once that waiver request gets to the federal level, there's going to be a very little that we can do to kind of stop that from getting approved. So really a lot of state level advocacy can be the best thing that you can do. I know that we have gotten a number of comments, and so I just wanted to, one question here is, want to talk again just about making sure that you're engaged with your congressional members, both your senators and your House member. We can't let this discussion lapse. It is very disheartening at times, but I think that the more that we engage in this discussion and the more that we keep the focus on access to care and access to a comprehensive benefit, the better that we will do for people experiencing homelessness who really have a critical need to life-saving care. I know we're at our half hour. I feel like this was just the tip of the iceberg. At this, I'll turn it over to Marcella for any closing comments she might want to make, but I just want to say to everyone, I appreciate your time today and your interest in action on this subject. So thank you very much.
Thank you, Barbara. For really, really valuable, helpful information, more valuable, post last Thursday than even before. And again, just want to highlight the point that Barbara makes, both to stay engaged at the federal level, and she gave you a lot of details on that, but also to stay engaged at the state level. Most state legislatures, if they are on a key committee related to health care, have staff that work on this issue. Health care, as our president has famously said, is complicated, and so also want to encourage that people get engaged with their state legislators legislatures, as well as their state Medicaid offices. That Medicaid Advisory Committee, again, a really good opportunity for people to understand that the negative impact that a lot of these changes, the barriers to care that a lot of these proposed changes would have. So thank you all for joining us, and we will be back in 2 weeks talking in more detail about essential health benefits and exactly what essential health benefits covers and the implications for changes that could be coming in that direction. So thanks, everybody, and have a great week.